webinar in our new PainCAS webinar series. My name is Elspeth McSorley, and I'm very excited to welcome all of you, and I'm happy to have so many of you joining us for this webinar. Today we're focusing on standardizing the assessment of patients with chronic pain. Before we begin, I'd like to review a few housekeeping items. Please call in through your telephone to receive audio for this webinar. Using your computer speakers will not work. And please keep your telephone muted at all times. We also ask that you please do not put your phone on hold. You can submit questions anytime during this webinar, but they will be answered at the end of the presentation. For help or to submit questions, please email me at emcsorley@painedu.org or through GoToWebinar's messaging provider. You should see something like this image on your computer screen. Under the audio setting, please make sure the button next to telephone is selected. And to submit questions, you can send them to me through GoToWebinar's question box. I'd now like to introduce today's presenter, Dr. Kevin Zakharoff. Dr. Zakharoff is a licensed, board-certified anesthesiologist with more than 20 years of clinical experience in anesthesiology and pain medicine. He is the Vice President of Medical Affairs at Inflection, an active faculty member at the State University of New York Stony Brook School of Medicine, a member of the Board of Directors of the American Society of Pain Educators, and the Medical Director of PainEDU.org, our website for healthcare provider education, and PainAction.com, our website for patients with chronic pain. Dr. Zakharoff is a co-author of a number of our print publications, including the PainEDU Manual, a pocket guide to pain management.
Thank you very much, Elspeth, and it's a pleasure to be here with all of you today. For those of you who are members of our PainEDU.org community, I welcome you, and it's nice to have you here. For those of you who are not members of that community yet, I urge you to become part of our 64,000 member and growing community devoted solely to the improvement of pain management. We've maintained a long and trusted relationship with the members of our PainEDU community, and we've tried very much to have a consistent voice and be a source of valuable resources and tools for people who are faced with managing chronic pain in their clinical practice, their clinical setting, or in their healthcare systems. Now, this is the first in a series of webinars that we're going to be doing, and it's intended really to do two things. One is expand the dialogue with you, our PainEDU community, and allow us to share information with you about new developments, about tools and resources that we've worked on to improve the management of pain. Another aspect of this, which I think is really important and goal for us, is to develop an open and bidirectional mechanism of communication with you and take our relationship to the next level. Over the course of this webinar series, we'll be presenting topics that we feel are engaging and relevant to you, along with topics that you identify as well moving forward. The topics for today's discussion are how variability in pain assessment can present challenges to the quality of pain care and workflow in the clinic and institutional setting. Also, we'll talk about how an electronic format pain assessment can help to standardize and streamline clinical workflow. We'll talk about the role of assessing and documenting risk of aberrant drug-related behavior in clinical practice, and this particularly is important when opioids are an appropriate component of chronic pain management. And lastly, we'll talk about PainCAS, a potential solution to some of the problems I'm going to identify. Now, if we think about the current climate in chronic pain management today, I'm sure this is one area for which we all have our own individual definition. Some of the things we've heard is that chronic pain is a big problem in our organization today. We've heard we're trying to develop policies, procedures, and protocols to help us manage chronic pain in our clinic setting in a controlled way. We've heard people say it's hard to get pain management in our institution or clinical setting under control. And we also all probably know that a lot of healthcare providers are fearful about prescribing opioids even when they're indicated because there's fear of regulatory scrutiny. The way I refer to it is sort of like a Groundhog Day phenomenon, where when I speak with people from different practice settings around the country, they all basically say the same thing. We had an interesting discussion with someone from a managed care organization in Oregon a few years ago, and I really think he summed it up best. He reached out to us because he wanted to license the use of the SOAP and the COM tools, which I'll talk about later, in his organization for his panel clinicians to help assess opioid risk. And he mentioned to us that he did a retrospective chart review of 500 charts of patients who had low back pain. Half of these patients were being managed by pain management experts, and the other half were being managed by primary healthcare clinicians. And what they found when they did this chart review was what he called the wild, wild west. There was no rhyme or reason to how these patients were assessed, no standardization in the way they were assessed, and no real rhyme or reason to the way the treatment plans were formulated. And we have to think about what we know. I mean, to some degree, each one of us knows that in our healthcare system today, there is little or no educational foundation for the management of chronic pain in many cases around the country. We also know that guidelines, despite the fact that they exist, in high numbers actually, often suffer from poor uptake, and this has been well published. This has the ability to result in a high level of variability in the way patients are assessed for pain, which is really the foundation of pain management. You know, my analogy for this is that I think of the pain assessment as the foundation of the house. Everything that takes place after that step is built upon the assessment. And if the assessment is variable, then that could lead to variability in the formulation of the treatment plan, the way patients are follow-up assessed, and the way their follow-up assessments are even planned. Transparency and communication across clinical settings suffers, and ultimately efficacy of treatment and satisfaction of both healthcare providers and patients suffers as well. What we hear from our Pain EDU community is there is an educational need for both healthcare providers and patients. There is a need for development and help with development for protocols of how chronic pain patients should be managed and algorithms to help clinicians who don't have the area of expertise in their back pocket to sort of plug patients into these algorithms. We hear from people that there's a need to help identify which forms of monitoring are appropriate for which patients and what to do when the results of those monitoring techniques come in, what the recommendations are. And we even hear that deciding when to refer a patient to someone with a higher level of expertise is something that is lacking. Sort of realizing when someone has reached their level of expertise and beyond which it wouldn't be appropriate to manage that patient is not necessarily clear-cut for people. We all know that there's a fear of regulatory scrutiny and that people want to do the right thing, but it's not necessarily so that people know what the right thing to do is. And lastly, and this is probably something we could all nod our heads about, is the fact that time constraint is a major problem. We want to do all these things, we want to achieve all these things, but as time moves forward, people have less and less time to devote to this. So it's a true conundrum. Now, the Institute of Medicine came out with a report back in 2011 entitled Relieving Pain in America, a blueprint for transforming prevention, care, education, and research in pain management. And a lot of people refer to this report. And when they refer to it, they talk about the financial burden of pain in the United States, which is huge. And they also talk about the number of people suffering from chronic pain in the United States at any given time. It's important to note, though, that this report mentioned a number of things that don't often get discussed. And that is that there are shortfalls in the United States with respect to chronic pain assessment and treatment planning. And very often these arise from educational deficits, as I already mentioned, research deficits due to the lack of good or any data, gaps in policies and procedures that are reproducible, deficiencies in treatment planning, especially consistency in the treatment planning, and attitudinal issues of both healthcare providers and patients. We also don't hear very much about something they mentioned, which is the cost differential between managing some patients who were poorly assessed and undertreated for chronic pain versus the adequately assessed and treated population, which is much less expensive to care for. So if you haven't seen this report, I recommend that you find it, that you set aside some time because it's over 300 pages, and you take a look at it because I think it has a lot to offer in terms of the current state of affairs and some of the potential solutions for some of these problems. The other thing we need to consider, obviously, in healthcare today is the movement towards electronic medical records. And if we think about just opioid risk assessments, tools that should be administered to patients in some way when opioids are an appropriate component of therapy, the impact of paper and pencil assessments is very limited in an electronic medical record world. There's no captured data from them. And they actually increase workflow, for example, with the SOAP tool, which needs to be scored by somebody. The cutoff score needs to be identified. The risk needs to be stratified. Then this paper document needs to be scanned and inserted into an electronic medical record. And from a different perspective, we're all hearing that electronic medical records actually steal time from the healthcare provider and patient communication in the clinic setting, because there's another thing in the examination room, and very often it's a tablet or a keyboard. Something else to note is that electronic medical records, by design, are fairly rigid. They're templated, and there's not a lot of room to modify them based on the individual clinical needs as they arise. And anybody who manages patients with chronic pain knows that no two situations are going to be exactly alike, and some kind of flexibility is going to be necessary. Let's just think about this. Let's say a patient's being managed for chronic pain, and opioids are not an appropriate component of therapy initially. But at some point during the course of the continuum of care, they do become appropriate. Just through an electronic medical record, it's not that easy to make the decision to now assess opioid risk. Things are fairly rigid, and I think we all know that. Now, when we think about assessment of risk of aberrant drug-related behaviors, hopefully most, if not all of you, know that we at PainEDU serve as the home of the screener and opioid assessment for patients with pain, the SOAP tool, and the current opioid misuse measure. And as I mentioned before, their value in a paper and pencil format in an electronic medical record system is limited. So we developed electronic versions of these tools, and we validated electronic versions of these tools. And our goals for developing them from the clinic perspective were to make it easier to document, to make it more consistent to administer these tools to patients, to standardize the way patients are assessed when opioids are an appropriate component of therapy, and to help start to scratch at the surface, if you will, of the beginning of a recipe or protocol for assessing risk. Now, if we track back a minute to the impact of variability in the assessment process, which we really should consider as the foundation of managing chronic pain, these are just some examples of the negative impacts that assessment variability can have at the patient care level. And for us at PainEDU, everything should be able to be reduced down to the patient care level. Lack of consistency in the way patients are assessed can lead to a variety of different problems. Just consider the fact that in a four-person practice, if all four people don't assess patients in exactly the same way, and the patient doesn't see the same healthcare provider for each visit, that could lead to a tremendous amount of inconsistency. We also have seen that if patients are assessed in a variable way within different clinics in an institutional setting, such as primary care versus pain clinic, that patients, when they change from one clinic setting to another, just think about maybe a patient who was originally assessed in the primary care setting, and the primary care people feel that it's an appropriate time now to refer that patient to the pain clinic. Well, if the assessment that was done at the primary care level didn't satisfy the needs that the pain clinic level has, then the patient needs to go through the initial assessment process all over again. There's a very, very big opportunity here for a lack of transparency when patients move through different departments within a given clinical setting. Also, this provides for the ability for inefficient utilization of resources, whether it's administrative resources in dealing with paper and pencil, whether it's inefficient utilization of resources with having patients need to take initial pain assessments over and over again as they move through different clinical departments. Now, one of the things that I think of when I think about the clipboard phenomena, which I call it, and we've all filled out clipboards in clinical settings over the course of our lives, I'm sure, is where are the pertinent positive pieces of information that are somewhere hidden in those pages on the clipboard? And more so, where is the data? What's happening to all of the answers to those questions unless they get captured by the eyeball of the healthcare provider? And what happens if they don't happen to get captured by that healthcare provider's eyes or mind? Not to mention the time that it takes to fill all of this out. I think it's reasonable to say that most of the places we've spoken to, when an initial patient comes in for a pain assessment for the first visit, it could take up to 20 minutes to fill out that clipboard. Now, I'd like to take a moment to talk about what I consider really to be a hallmark article that was published in Pain Medicine back in 2005 by Doug Gourlay and Howard Haidt. And Gourlay and Haidt laid out a fairly easy to implement, very cogent plan for assessing and treating patients with chronic pain. Sometimes, unfortunately, I think it's one of the best kept secrets in healthcare today. And if you're not familiar with this article, I highly recommend that you write this down and get it. There's a lot in it. There's certainly an article on PainEDU where we summarized the content of this article if you'd rather find it on PainEDU instead of going to the source. And it's not perfect, but it is reproducible. And it did highlight a number of clinically relevant steps that could be implemented for chronic pain management. One of the key points of this paper is the importance of the assessment process and its role as the foundation of treatment planning and follow-up. So I've laid out a number of challenges that exist in our country today with respect to assessment, with respect to standardizing assessments, and with respect to our movement towards electronic medical records and making sure that patients get reproducibly assessed and treatment plans get reproducibly formulated. And now what I'd like to talk about is a new solution from PainEDU. It's not our first solution, because any of you who are familiar with our website know that what we do is provide solutions for problems that we've identified in chronic pain management. And today I'm going to talk about the solution called the PainCAS Clinical Assessment System, which is designed to address these challenges, and it does address these challenges by standardizing the pain assessments to help improve the quality of care, by streamlining the clinical workflow process with electronic pain assessments, and by helping to improve compliance in assessing and documenting risk of aberrant drug-related behaviors when assessing that risk is necessary to be done. PainCAS is a web-based clinical tool for assessing pain and opioid risk in chronic pain patients. That's about as succinctly as I could state the definition of PainCAS. And it's worth taking the time to note the lead team of the PainCAS program, which is myself, Dr. Steve Butler, who's the Vice President and Chief Science Officer at Inflection. He's also extremely well known in the community as the father of the SOAP and the COM tools. Dr. Robert Jameson, who's a psychologist at Brigham and Women's Hospital and professor of anesthesiology at Harvard Medical School. Sadaf Charity, who's the project manager for the PainCAS program. Elsbeth McSorley, who's the communications manager. And a noteworthy participant who is not on this screen, Kristen Lawler, who is the senior research coordinator for the entire development process of PainCAS, who has now moved to the Dana-Farber Institute. She deserves a lot of credit. And behind this lead team is a very large number of other staff who have helped bring this program to reality. Now, when we talk about the development of this tool, it's worth mentioning that it was entirely developed with NIH funding. We did also have consultant input from around the country, as you can see on this slide, but I'll just take a moment to talk about the NIH grant funding and how this program came to be. And it's important to note that it is now commercially available. We started off with a phase 1 NIH grant, which involved developing the prototype of this tool, testing the feasibility, and using a process called concept mapping with more than 30 clinicians who were comprised of physicians, psychologists, nurses, nurse practitioners, and other types of healthcare providers on important topics and questions that should be included in the PainCAS assessments. We didn't feel comfortable just saying this is what we thought should be in these assessments. We wanted to get everybody's feedback and come up with a first best guess based on everybody's input. Acceptance testing of that prototype was then done with both 30 clinicians and 30 chronic pain patients as well. And as part of this phase 1 process, we validated electronic versions of both the SOAP and the COM tools. When we moved into the phase 2 NIH grant, that was the actual process by which we developed the final versions of the initial and follow-up assessments, which involved consultant review from these organizations around the country, and then final revisions of the assessment to make sure that they were not too lengthy and captured what mostly everyone felt should be captured as part of a good comprehensive pain assessment. Then we did cognitive interviewing with chronic pain patients and usability testing to see whether or not patients felt that it was an easy program to use. And then lastly, we embarked on a program study at 3 various clinic settings to make sure that PainCAS lived up to its promises. When we think about the clinical utility of PainCAS, I think what we really need to focus on is the fact that it standardizes the assessments. It replaces the paper and pencil pain assessments that people are currently using. It encourages dialogue and transparency, not only within a clinic setting, but also between healthcare providers and patients. And I'll talk about that in a minute. It integrates the validated opioid risk assessment, SOAP and COM, right into the assessment. So nobody needs to think about whether or not a SOAP or a COM needs to be done. It's actually woven into the assessments themselves. It is in an electronic format, so it provides for improved and streamlined documentation process in electronic medical records. And it also provides for remote capabilities because patients can complete this anywhere that they have the ability to connect to the internet. And I'll get into that in a little bit more detail. The output of PainCAS, we've talked a lot about the assessment. The output of PainCAS is reports. So think of the value of a 6, 7, or 8-page paper and pencil pain assessment that's sitting in that plastic holder outside of an examination room. How can a clinician possibly distill down quickly what's going on with a patient when they pick that up as they're walking into the examination room? I would posit they can't. Our PainCAS clinical assessment system provides 2 types of reports. One for the healthcare provider that bubbles to the surface the pertinent positive information that's prioritized in an at-a-glance graphic format. It graphically allows for trending change over time and also puts right up front and center monitoring recommendations based on the opioid risk assessment, which would be woven into the pain assessment. And it additionally links to educational content for healthcare providers on painedu.org. That's pertinent to the things that the patient said in the assessment itself. The other report output that PainCAS produces is patient reports. Reports for patients that are in a report card format that show change in pain and function over time and links to our patient education website, painaction.com, for educational content. And the reason we put so much stress on the development of patient reports was so that the patient could also use it as a springboard to further communication with the healthcare provider about what the report card says. So let's take a look at what these reports look like. And hopefully what you're going to feel is they look dramatically different than the assessment that you're using in your clinical settings today, or if you don't have a clinical setting, what you've seen in clinical settings. This is a clinician report. And what the report summarizes is it summarizes the pain assessment in an easy-to-read format with the critical information highlighted and the clinicians alerted to information that is important for them to consider or to help them think about using that information to seed further discussion with the patient. The reports include pages presenting every single question with every single patient's response for documentation purposes, but what is put right up front and center for the healthcare provider is what is going on with this patient, which hopefully you can see on this slide. And once the patient is assessed more than one time with PainCAS, as you can see on the right side, trending starts to take place so you can see change over time. This is a lot different than just asking a patient what's their pain on a scale of 0 to 10. And even if you do that on every visit, how are you going to know with respect to pain and function, for example, what's happened over the course of the last 6 visits with the pain assessments that you're currently using today? It's food for thought. From the patient report perspective, as I mentioned, it's a report card-like report to show progress and facilitate discussion with their clinicians. It's also worth noting that during the Phase 1 NIH grant, that patients felt more informed and involved with their treatment when using PainCAS as compared to traditional paper and pencil pain assessments. And interestingly, and we didn't query for this, but the patients who participated in the study told us this, they told us that they felt the clinical engagement began as soon as they started completing the PainCAS assessment, even if they were completing it at home in front of a computer. That really surprised us. If we think about the benefits or potential benefits for clinicians, I think we have to consider that standardization benefits clinicians as well. It gives clinicians the confidence that everybody is going to be asking the same questions, and nobody has to worry about the fact, well, if I were doing that assessment, I would have made sure to ask that question. The remote capabilities are another plus. Assessments could be completed by patients who have access to the internet on a computer, on a tablet, or in the clinic on a computer or in a tablet. I mean, the ideal point in the distance is where most patients have access to the internet, and they can complete this, and this actually becomes a requirement for that visit. And if it hasn't been submitted yet, that the patient is reminded that they need to complete this in order to come for their visit. Also, from the clinician perspective, the at-a-glance reports provide for streamlined clinical interpretation, facilitate compliance with existing policies and procedures, potentially can improve patient and healthcare provider communication, and also links to both patient and provider in education that is pertinent to the specific patient. It also additionally provides for monitoring recommendations based on the patient's level of opioid risk assessment. From an organizational perspective, standardization, we also posit, is a very big benefit. Streamlining workflow is also a big benefit. Reducing variability, optimizing resource utilization, and we are going to be able to answer the data question. PainCAS captures data for us and can capture data for you. And this data can be used for a myriad of reasons, including the fact that we know the Joint Commission is setting its sights at an institutional level on pain management. We know that HCAP scores already look at pain management as one of the aspects of satisfaction surveys with patients. And just from a quality assessment perspective and an outcome measurement perspective, the data that has not yet been measured or available to be measured will now be available through this tool. It's important to note that we did not leave out the administrative people in this program, and that we took the administrative personnel into account when we developed this tool. It's flexible, and it can be implemented among a variety of different sizes and types of clinical settings. And currently, there are 4 different question sets that live, if you will, within the PainCAS assessment. There's the initial assessment, there's the follow-up assessment, there are all versions of the SOAP tool, and then the COM tool as well. And these assessments can be mixed or matched in any way that someone desires, except for doing an initial and a follow-up assessment at the same time, which would be incongruous. But if someone wants to use this program and they feel that opioids are not an appropriate component of therapy, therefore there's no reason to weave in the opioid risk assessment, that could easily be done. Someone feels that I'd rather continue using my current paper and pencil risk assessment, but I like the electronic version of SOAP and COM capability, then they can just select that as well. So it is pretty flexible. And we're just going to spend a minute or two looking at what the patient sees, and then we'll move on to questions and answers. So this is a sample assessment of what a patient would see when they're asked where the location of their pain is. And they get asked the location. It's worthwhile to note that if they have pain in more than one part of their body, that they can select more than one part of their body, and they're also given the ability to see both the front and the back of the body as well. Keep in mind, this is all then stratified into a report that tells the clinician where the pain is and what the patient's experiencing. We tried to make it very easy for patients to use this program so they can just, if they're using a tablet, such as an iPad or a computer, they can just move their arrow over, in this case, their pain rating, and just click it and go on to the next screen. We also give patients instructions when they're going to complete the assessment about what they will need to have handy in order for them to successfully complete it, such as either the medications they are currently taking or a list of the medications they're currently taking. And during follow-up assessments, PainCAS will have the capability to identify and query for medications that have been started or stopped since the previous assessment as well. The reason we're looking at this screen is to just highlight the fact that the question sets in PainCAS are dynamic, and they branch based on answers to certain questions. So if, for example, a patient was asked a question about how often they consume alcohol, and they don't consume alcohol, then they will not get the branching question about how much they drink. If they do say that they drink, then they will get the branching questions that stratify down more details about the alcohol consumption. And this just is one example of the branching capability and how the question sets contract and expand as needed throughout the assessment process. Another interesting thing we found out with the Phase 1 grants was that even when people use the paper and pencil pain assessments, that there were things that the patient wanted to say that the assessment wasn't giving them the opportunity to say. So a lot of clinicians and patients would tell us that they would be writing on the sides of the page or on the bottom of the page or anywhere they could find blank space to also add the information that they wanted the healthcare provider to know. So what we did is we built that capability into the PainCAS assessment, and we allow the patient to enter free text so they could additionally make other thoughts, comments, or questions that they had for their healthcare provider when they were taking the assessment, and these would also bubble to the surface for the healthcare provider when they were reviewing the report from the PainCAS assessment. So I will take this opportunity to stop now and entertain questions that you might have.
Great. Thank you so much, Dr. Zakharoff. The first question that came in is, how does PainCAS link to other tools and educational resources?
Well, the way we really looked at the development of this tool is we felt that this was a perfect opportunity to allow our educational initiatives, both PainEDU and PainAction, to interact at the clinic setting level. I call it a window into clinical practice. So PainCAS will automatically, through markers that we've identified in the assessment, identify existing content on PainEDU and also identify existing content on PainAction and automatically make links to those pieces of content part of the reports that both the healthcare provider and the patients receive respectively.
Thank you, Kevin. The next question is, what type of clinical setting is PainCAS best suited for?
Thanks, Elizabeth. We gave this a lot of time, and we went back and forth about this a lot when we were developing this tool. On the one hand, one of the things we heard from our consultants when we were developing the tools was that pain experts really felt that they just needed something that was going to streamline the process and get things done in a more quick, streamlined way. They didn't really feel they needed the monitoring recommendations or things like that. We heard something very different from the primary care clinicians that participated in the study. We heard that they really felt they needed help and needed something that was in a much more templated kind of way. So I guess, Elizabeth, my answer to that question would be, it's both. It has a lot to offer. For someone who is looking to just implement something that's reproducible, and they're in an expert level setting, and they really are just looking to improve documentation, PainCAS is very well suited for them. For people who are in a non-expert setting, who really aren't 100% sure of the right questions that people should be asked, in a primary care family practice setting, it's a perfect solution for them. So we talked about what the best setting would be, and where we shook out was that it's probably likely both. And it's really up to the individual clinic setting to figure out whether or not this tool is best suited for them. But given the current climate, I would really say it's pretty much suited for any clinical setting that is doing assessment of patients with chronic pain.
Thank you. Okay, the next question many people are asking: does PainCAS integrate with electronic medical records?
So it's a great question. We have a lot of experience with working with electronic medical records, and I hold privileges at 2 different hospitals that are pretty geographically close to each other, but use 2 different electronic medical record systems. And what we did with our first commercial version of PainCAS is we made the output a PDF format, so it could easily be attached as a PDF document to any electronic medical record that is out there. We didn't want to try at first blush to tackle the interoperability issues that exist between the electronic medical record systems themselves. So current version of PainCAS that's commercially available, PDF format. Tune in 5 years from now when we're dealing with version 3, 4, or 5. It's much more likely that we will have electronic medical record versions of PainCAS that interoperate with different electronic medical record systems that rise to the surface.
Thank you, Dr. Zakharoff. This is another question that's coming up with many people. How are the assessments developed?
Well, we as I mentioned before, we didn't want to sit down amongst ourselves, Dr. Butler, Dr. Jameson, and I, and figure out what we thought were the best assessment questions to include. So we reached out to over 30 healthcare providers around the country, both pain management experts, primary care physicians who had an expertise in managing pain, and primary care clinicians who did not have any area of expertise. And from those, we used a scientific methodology called concept mapping to stratify and hone down the assessments that we developed. We also did cognitive interviews with patients to make sure that when we were asking the questions as part of the assessment, we were asking the questions in a fashion that someone even with a 5th grade reading level could understand.
Thank you. All right, the next question I pulled is, can patient assessment data be shared between or within organizations?
So that's a great question because it comes up a lot. Data that's captured can be shared within an organization that has multiple clinics. So let's say we're dealing with a large academic institution that has a primary care clinic and a pain clinic, for example. If the patient is seen in one of those 2 clinics, then the PainCAS data can move seamlessly between those 2 clinic settings. But the PainCAS data cannot move between different organizations. That would be a violation of HIPAA. And unless there was a specific request that was made to the individual institution or organization that housed the data, and that institution then made the decision to forward that data to the new organization, that's the only way that data could be transmitted from one organization to another. We would not have the ability to move data from one place to the other. As a matter of fact, the only data that we have access to is de-identified aggregate data. So we could not do it even if we wanted to.
Thank you, Dr. Zakharoff. The next question, Will the data generated in a PainCAS report guide the healthcare provider or patients to a specific area on PainEDU or PainAction for content? Or would healthcare providers and patients have to go onto our website and search for information on their own?
Yeah, that's another great question. We developed it in a way that will only guide the healthcare provider or the patient to pertinent educational information. So it ends up being a pretty cool way to educate people, because if a patient, for example, came in, filled out the PainCAS assessment, and let's just say they had chronic regional pain syndrome, the report for the healthcare provider would automatically point them to educational information on PainEDU, specifically dealing with that subject, and possibly other pertinent information about managing neuropathic pain. Same thing would happen on the patient side. The patient report would have similar targeted information that exists on painaction.com that's pertinent to the patient's clinical condition. Now, it's not entirely impossible to think that there might not be general content, which is important for everybody in this story, and that will be offered up as well. But if a patient came in complaining of back pain, then there would be no reason to think that the educational information in that patient or healthcare provider's reports would be in any way similar to the chronic regional pain patient reports.
Great. Our next question is, who in the clinic or the healthcare setting or the hospital would be involved in the implementation of PainCAS?
Yeah, so this is something that we have had a lot of experience with already. And it's reasonable to think that the administrative staff are going to play a very large role in the implementation of PainCAS. Unless we're dealing with a clinical practice setting where the clinician is intimately involved with the administrative duties, I think a lot of this will be handled at the administrative level end. It's reasonable to think that from the healthcare provider perspective, they will be most interacting with the reports that PainCAS generates. And they will also be interacting with the patient with the reports that the patient gets as a result of the PainCAS report.
Okay, we have a number of questions on how can people get a look at PainCAS, demo it, see what it's like, and then also we have a number of questions on how does someone get started using PainCAS.
Okay. If there are no further questions beyond that, then we can move to the next slide, which I will leave to you, Elspeth.
Okay, thank you very much. All right. So, to all of our attendees, we hope you enjoyed today's webinar. We would greatly appreciate your feedback, so please take a few minutes and answer the post-webinar survey. You'll be emailed later today. If you had questions that were not answered today, and I know many of you did, there were lots and lots of questions coming in, and I'm sorry we couldn't get to all of them. But there is a section in the survey where you can submit your questions, and we'll be happy to get back to you. We invite you to visit the PainCAS website at PainCAS.com, and we'd love to hear from you. So please feel free to call us at 877-207-0645 or email us at support@PainCAS.com. Thank you so much for attending today's webinar. Our next webinar will take place in September, so stay tuned for details, and we look forward to having you join us then. Enjoy the rest of your day, and thank you again.